Dr. Chang attended Stanford University for undergraduate and then went on to complete her medical school, residency, and fellowship at UNC Chapel Hill. She served as an instructor in nephrology at UNC in 2015 and is now an assistant professor of medicine at UNC. Dr. Chang's clinical and research focus is on chronic kidney disease. She initially began her research from a basic science focus, looking at mediators of acute kidney injury and fibrosis in the kidney. She now focuses on the development and application of radiologic techniques applicable to patients with chronic kidney disease. Dr. Chang, thank you so much for coming to speak with us and to share some of your experiences. We are all very excited to hear you speak about nephrology, especially because today is World Kidney Day.
Yay, it is. Can I share my screen? I had a couple of things I wanted to show you.
You can go ahead and share your screen.
It said that you disabled it. It won't let me.
1 second. Okay, you should be able to go ahead and share.
Okay. Okay. So I'm here to talk to you about nephrology. That's my area of specialty, and these are kidneys. This is a few years ago, my colleague made these cookies, and I thought they were delightful. So they were our they may still be our Twitter on our main page because I think they're so cute. But today, actually, for World Kidney Day, one of our fellows' wife made new cookies, so we may have to supplant this one. But I love these. So I really, the slides really are just here kind of to trigger me to remind me for what I wanted to talk to you about today. So I thought about what you guys, I guess, before virtual world did was you wanted to shadow and see what different specialty doctors do. And I think that is actually hard to capture for a lot of specialties and definitely for ours because there's so many different aspects of what we do. But I thought maybe that might be an advantage of this virtual presentation. And I could walk you through a bunch of these areas. Some I'm more familiar with based on my background and current job description than others, but a lot I know about. So, and the reason I have this diagram here is because everything we do is centered around the patient. That's true for everyone. It's true for us. All of these aspects of care, every nephrologist and faculty and support team members, our nurse practitioners, our nurses, our research staff are all here because of the patient. So it all comes back to that. So one big part of what we do as nephrologists is simply think. And we sort of have that reputation too as a thinking specialty. We like to ponder situations. We like to gather data. We like to gather histories, exams. We like to look up studies. And then we like to sort of put it together. And I almost think of it sort of like a murder mystery. We like to sleuth to figure out what the solution is. Of course, you have to do it really fast sometimes in high intensity settings in the hospital. Hold on a second. I'm having a fly problem, and there were two staring at me. Like obsessed with flies, with this fly problem here. And that's a reputation that we carry, and it is a big part of what we do, and it's a lot of why people become interested in nephrology. But as you'll see, we do a lot more than that. And I think sometimes people get scared away from nephrology because they think it's such a heady specialty that's all we do. But I hope to illustrate to you that we do a lot more than that. So next I wanted to talk about diagnose. So in addition to thinking, sometimes we have to do more than just information gathering, more than looking up studies, more than talking to the patient. Sometimes we have to draw certain labs. And in this picture, I depicted something we do quite commonly, which is a kidney biopsy. And that's one of our big tools of diagnosis. And it is a hands-on procedure. So it's sort of a a combination between thinking, because you have to think to decide you want to do the biopsy. And it does take a lot of thinking, because doing a biopsy is not a risk-free procedure. In fact, it has some pretty big risks involved, and it is not a cost-free procedure. It's pretty expensive and is not a time-free procedure. It takes a minimum of a day for a patient. So it takes a lot of thought going into deciding who gets a kidney biopsy. But then you get the hands-on part, which is what some people really enjoy. And I'm really not a hands-on nephrologist. I'm that thinking heady kind of doctor. I like to sit and look things up and talk to patients, and I really like working through all the points. And I guess I think of myself as sleuthing to figure out what's happening. But this is the one hands-on part I like, and that's probably because of my radiology interest. I have an interest in ultrasound, and we use ultrasound to guide ourselves while doing the biopsy. So this is probably the most hands-on that I get, and it's quite it's really satisfying to get a good kidney biopsy result. So then you have to think on the other end of it too, because you get a result and you have to make a diagnosis and make decisions about treating. So there's thinking couched on all of this. But the diagnosis is a big part of what we do. There's some debate in the field because we share that responsibility with radiologists. We do it and they do it. But for some nephrologists, it's a really fun part of their job. And then I thought I would mention next research, because it is sort of tied into it's a lot, at least here at UNC, a lot of the research we do is tied into this diagnosis. There are certain rare, not completely rare, but rare diseases in kidneys that require kidney biopsies to diagnose. And we have a robust research program here looking into that group of disorders. Things you may have heard of, lupus is one of those in that area. It's sort of these autoimmune diseases. The other ones may be less common that you might not have heard of, but regardless, the point is we that's sort of the original solid. We've been doing that research for decades, but there's a whole lot more to the research beyond that group of diseases. So we also do a lot of research on your basic chronic kidney disease, and we recruit patients for clinical studies all the time. So we have a robust clinical trials group, and that means patients who come to see us for whatever reason. They were referred for something that their primary doctor detected was wrong in their kidneys. They go through this process where we think through, should we biopsy them or not? They get a biopsy. They're diagnosed with some autoimmune disease. Well, we have a number of clinical trials that recruit through us that we're a part of, amongst other places, and patients have the capability to enroll in those trials, which allows access to a lot of cutting edge medicines. And you are in a trial, but you might be familiar with in cancer, that's a lot of the way people get some of these higher level drugs, A, who can't afford them, or B, who might not have responded to your first line treatment. Part of our research, because we have in the clinic, we see the patients frequently, is collecting of their samples so we can run other tests on them to try and figure out other ways to diagnose, try and think about how the disease process is happening. So a lot of it has to do with collecting clinical samples. So we have a lot of our study people that are running in and out of clinic, talking to our patients in between when we're talking to them, and they're trying to collect their samples. So if you were there shadowing one of these doctors who sees these patients, you might see these random people coming in and out of the room when we're not in there, and they're talking to the patients because they're already enrolled in the study, or they're trying to enroll them. They're collecting information or data on them. And then in addition to that, we have a whole lot of other areas of research. So if you were to shadow one of our doctors that were primarily research, it probably would be boring a lot of the time, because they'd be sitting in their office writing, or talking to people on the phone, having lots of meetings. Some of the more hands on the ground kind of exciting stuff, they might be in the dialysis unit, recruiting patients there too. So talking to patients. So there definitely is hands-on stuff, but for the higher level, some of the people who are what we call principal investigators or PIs running the study, a lot of times they're really, we're just sitting in our offices writing and talking to people. So no fun to shadow those people. But it is important and fun to shadow some of the work they do on the ground, because it helps to know, you have to have gone through that to be able to write these studies and to design them. There's also things like registries recruiting patients who have certain diseases just to be kind of in a data bank, so that if things come up, we know how to reach them, but also we can pull data on them. There's people who do epidemiological studies, which means they go through a whole lot of data that's already there collected for other reasons, or in our electronic medical records that's just sitting there, and they know how to go through that, ask a specific question and try to find the answer to it. And that takes a lot of thought too, because you have to figure out how you want to design your question, which patients, and how to find those patients not find them physically, but find them in a database, and how to do a search so that you can answer the question that you want to answer. And it's a lot trickier than it sounds. So that's a whole nother group of researchers, and that involves people trained in epidemiology and statistics. But some of our nephrologists have that training and work with people with that training. So that's another area. Okay, so I think that's what I wanted to say about research. And the next area I wanted to talk about was really important one, and this is one that consumes a lot of our time, and that's the actual giving of the care. And this is probably what you'd see a lot of if you were to shadow us, and so we would highlight that a lot. But what this virtual platform allows me to do is to show you that's not the only thing we do, but it is the easiest thing to shadow. And our care happens a lot in the clinic. So you would see doctors talking to patients. You may see nurses triaging patients. So they would get their blood pressures, their vital signs, collect their current medicines, any allergies, updates. And then the doctor would come in and sit down and talk to them, do a physical exam, and do an assessment and talk to them about their prognosis, any changes that need to be made in their care. So it sounds simple, but it's not that simple. And we have come to, I guess the older you get, the more you recognize the nuances. And I graduated from med school in 2007, residency in 10. So I guess I've been a practicing MD for 11 years now. You definitely, as you age, a lot of it you don't learn in medical school, you don't learn in residency, you only learn with time. And it's the nuances of how to give care, how to figure out from the patient what you need to know to make a diagnosis or to change care, or how to get the information you need, especially in very limited time that we're given. So it takes a lot of, anyone can give care, but to give good care takes a lot of experience, time, thought. So if you've been to the doctor yourself, you've probably seen a wide range of quality of care that you've received. And as far as giving care, we do things like the actual diagnosis. So that may take however many visits. After they're diagnosed, do they need to keep following it with us? Is it something that we're actively treating? So we may need to assess how things are progressing, how they're responding to our care. We also new therapies. So the last couple of years, in a way that hasn't happened before, there have been a whole host of new medicines that have come about for the care of diabetes and chronic kidney disease, which was static for so long. We had nothing to offer, same thing over and over and over. So it's actually been really fun in the last couple of years because we have things to offer. And that's why, you'll hear ads, people go, ask your doctor, because there are new things now. And we used to not be able to say, it's like, we got nothing. Or they'd say, can't you cure my kidney disease? And I still can't say yes to that. But now I can say, if you're not too bad, right now I can give you this and we can slow it down and we can hopefully prevent you from getting to the end stage. So that's kind of fun to be able to say when I wasn't able to say that before. So part of what we do is introducing any new therapies that have rolled out, and then potentially enrolling people in studies like the research so we work, kind of in collaboration with our research physicians, and sometimes it's the same physician, and then manage all the complications that come about because of our different kidney diseases. So it's a lot to do in one visit, and sometimes you only address one part of it. And sometimes you have a very comprehensive visit. But we also have specialized, so within the specialty of kidneys, we even have subspecialties, so super specialized. So you think you couldn't get more specialized, you really can. So I was brainstorming of all our different specialty clinics. So there's transplant clinic, stone clinic, glomerular nephritis clinic, hypertension clinic, myeloma clinic. We even have a pregnancy clinic, and we have a kidney palliative care clinic. So there's a lot of specialty kidney care, subspecialty kidney care that we do too. So while on the surface to you, if you were to shadow, it might just doctor going in and out. There's definitely a variety of what we do, and you would see different kinds of care and different approaches to care being given. So, and you guys can stop me along the way anytime, because I know it can get boring, or you might have a question about some things. So just holler, unmute yourself and holler if you have a question. And I don't think I can see the chat when I'm presentation mode. So if something comes up in the chat, Margaret, if you could let me know.
Yeah, I'll let you know if anything comes up.
Okay. So the next topic is a guide. So one of the big areas that we see is what's called chronic kidney disease. And we have all these other specialized things like stones, like these autoimmune diseases, but chronic kidney disease is kind of like the bread and butter of dialysis. And that's what I do. That's a lot of the patients I see, and I love it. And it's sort of the not sexy part of nephrology. It's the sexy part is the biopsies, it's the autoimmune diseases, because you're giving high level, almost like chemotherapy type medicines, and patients get really fast sick really fast. They go in the hospital. It's kind of dramatic. It's like dramatic nephrology. If they were to have a like a TV show about nephrology, Grey's Nephrology, it would probably be a lot of glomerular nephritis, autoimmune diseases, but it's really the chronic kidney disease that affects everyone. And chronic kidney disease is it just means any kind of kidney disease. So all these other diseases are chronic kidney disease, but your basic bread and butter chronic kidney disease in the United States is diabetes and or hypertension related. And I like to tell my residents, med students, whoever's working with me, I love chronic kidney disease, because what it allows me to do is get to know the patient, because they tend to follow with you forever, because it doesn't go away. We don't have a way to cure it. So it's not like cancer, where if they cure it, you may graduate from their care. You don't need to see them after a while. Or surgery, where you have the surgery, once you're good with the surgery, you don't need to come back. It's like with us, a lot of our patients are with us forever. And for me, I love that part of it. I also really like old people. So there tend to be a lot of old people here. But what is so fun about it to me is you get to spend your time getting to know the patient, because it's pretty recipe, kind of cookie cutter. And I am condensing, making it sound a little more stupid than I mean it to sound. But the basics of what I do in terms of the medicines, it's not that hard, but it allows me to focus on the other part, which is what's right for this patient, what's going to work for this patient. Here's what I would recommend medically, but what's the patient going to be able to do? Because what can they afford? What works in their lifestyle? What diet changes are they willing to make? what will they lie to me about? Trying to establish a rapport so they don't feel they have to lie to me, making compromises with them. So I love that stuff, like figuring that stuff out. Whereas if you're in one of these high drama clinics where people get really sick really fast, you have to just go, make those big decisions about those infusion medicines, things like that, that you do get to know the patient, but you have to make these very important decisions. You have to focus a lot of your brain power there. I like focusing my brain power on getting to know the patient. So that's my plug for chronic kidney disease. But the reason this comes up in my guide section is because you follow these patients forever, and your hope is they're never going to get worse. Their kidneys are going to stay perfect, stable forever. So they'll have chronic kidney disease, but it's stable, and they'll never get to the end stage. That's your hope, but that doesn't happen for a lot of patients, and a lot of patients progressively get worse. And so you kind of, for chronic kidney disease and other diseases, but a lot for chronic kidney disease, you act as their guide. And sometimes for those other diseases, as they get to that point where they're not treating them actively anymore, they may hand them over to me to help guide them through the process of, okay, your kidneys are going to get worse. What do you want to do? And we used to, in the old days, by old days, I mean 10 years ago, we used to say, okay, you need dialysis, so you're going to get started on dialysis, and that's the, here's the next step, next step, next step. Thankfully, us and all of medicine is moving more into patient-centered care. And that's why I call it a guide. So I'm here as a guide at that point. Here's what I think may happen to your kidneys in the next few years. Here are your options. Let me hear from you what is important to you, and how do we move through there? And let me get you all the information you need to help make a decision, get it to your family members, your caregivers. So I love this part of it, the guide part of it. It's part of the CKD part, that the chronic kidney disease, that's what CKD is, chronic kidney disease, that is really, can be hard, but fun and very time consuming, but really allows you to individualize for each patient. So, and one thing I want to say about that is that this sort of patient-centered approach, we used to just say, okay, dialysis. Well, that has really evolved now to where it's a lot more interesting and fun because we have a lot more options for dialysis. And I'm going to tell you about that in a second. But we've also brought into it this kidney palliative care clinic I mentioned. I actually helped to start that. One of the choices that we're really starting to emphasize is medical management without dialysis, so that they understand what their life would look like if they chose not to do dialysis, but their kidneys got worse, because that's a choice too. A lot of times we had been trained to think it's not a choice and they have to go on dialysis, but that's not true. And that's what a lot of patients think. So that's a big part of what I consider my job and this work in the kidney palliative care clinic. Okay. Next, lest you think we're just a thinking specialty, I wanted to make sure because I think a lot of people don't know. I've even had med students who did not know, residents who do not know that we actually have a very hands-on component. It's a growing part of our field. And we have actually 4 of our doctors who are what's called interventional nephrologists. And you can see here, this is practically surgery. They're gowned up, sterilized, just like a surgeon would be. And this is Dr. Swain. He's one of our interventional nephrologists, and he's training our fellow, Patrick Taus here. And what they do is work on vascular access. And I'll talk to you about that in the next section. But they have a whole procedure, a whole building of their own, Carolina Vascular Access, that is where they just do procedures. So it's not full-blown surgery, but for people who think that they would really miss a hands-on component and think that's why they don't want to go into nephrology, think again, because you can definitely use your hands. For the biopsy and the vascular access are probably our 2 main hands-on. And Dr. Swain spends a lot of his time doing hands-on stuff. So it's definitely a robust field, and there are more and more people doing interventional. And it's nice, especially for people who love using their hands. There are certain surgical specialties that, and I don't mean to diss on surgery, like who think more than others, and some that really just need to use their hands. Everyone thinks, obviously, I'm not saying that, but some think, like, have to think more than other specialties. Actually, one of the jokes that I like, and it's not meant to be mean, but there's a medicine doctor and a surgeon running to catch an elevator door that's closing. The medicine doctor will put in their hand to stop the door, and the surgeon will put in their head to stop the door. So I always think that's funny, but and I don't think a surgeon should take offense, because their hands are precious to them. They need their hands. If they didn't have their function in their hands, they couldn't do what they need to do. And a good surgeon has good hands, and they want us to think. But this is a nice area, the interventional nephrology, where Dr. Swain gets to use his hands, but he also has to think a lot. I mean, he sees clinic patients too, but in terms of the access work he has to do, he has to think a lot too. So that's a nice intersection. And then for those people, I've been referring to something called end stage, or we're moving to calling it kidney failure. And so as we move along sort of the give care, the diagnosis, the guide, when we weren't able to reverse it, when we weren't able to treat it, when we weren't able to stop the kidneys from getting worse, what happens is they fail. They can't do what they're supposed to do, which is clean your blood anymore. People may stop making urine. We thankfully, it's sort of like a blessing and a curse. We have something for them, which is dialysis, but dialysis is really hard to tolerate. So that's definitely a big part of what we do. It's kind of one of our money makers, taking care of dialysis patients. You've probably passed dialysis centers. You may not have even known it, but they're all over everywhere. I mean, there have to be dialysis centers everywhere. These patients don't go to a hospital for all their treatments, and they go get treatments 3 times a week if they're doing the kind of dialysis where you go to the center and get treated. So that's a lot of time and effort on their part, but it is a life-saving. So it's kind of like life support. It does keep them alive. It's just not that easy to tolerate. And there's a lot of work being done on different modalities. Used to be just kind of one thing, but there's dialysis you can do through the belly. Now there's dialysis you do through the belly at home. There's also now you can do the hemodialysis through this kind that I show a picture of here, which is through your blood. That can be done at home now too. So that field is becoming more robust, with more options for patients, which is nice to have more options. But it's definitely a big part of what we do. A lot of times students, trainees, learners don't see that because we don't really bring them into our dialysis units. And it's a love-hate relationship. Some people love it because you have easy access to the patients. They come 3 times a week, as long as they're coming regularly. Some people hate it because it is exhausting. Sometimes the patients come to depend on you, can be needy, but it's also in some ways really nice. It's like a little community there. For some patients who are isolated, they go to you may have seen it on TV shows. It's for some patients, it becomes their second family. So there's pluses and minuses to dialysis, but I just show it to let you know it's a big part of what we do. And if you decide to go in the field, it's at least important to understand that. Not all our doctors take care of dialysis patients. The ones that go into transplant, for instance, they don't really take care of dialysis patients except in the hospital. So you can design your career with what you like, depending on where you're at, how flexible your employer is, and what your interests are, because not everyone does all of these things, obviously. And I guess everyone does this. So mine is composed of this, a little bit of this, used to be more, but I'm less of this, I guess I do a little of this. I don't do this, and I do a little of this too. So one other area that I wanted to bring up was collaboration. And if you choose to go into the field of nephrology, you will, of course, have to love the kidneys, but it is a field where you do heavy collaborations. You will never be in want of knowing a good doctor in most other fields. So as I was preparing this, I try to think of all the people we regularly collaborate with. And I'm regularly, like routinely, and we also have less regular, but it was a long list. So I'm going to read it to you so you can see. We collaborate regularly with cardiology, endocrinology, rheumatology, dermatology, pulmonology, plasmapheresis, hematology, oncology, urology, radiology, OBGYN, palliative care, geriatrics, vascular surgery, transplant surgery, ENT, pathology. And those are all our very routine, like, and some of them we even have joint clinics with. So it's a very collaborative subspecialty that we're in, and we emphasize that because it's a better way to give patient care. So that's kind of how I wanted to summarize nephrology, but I thought I would take this opportunity, since you all are here at UNC, to tell you a bit about UNC nephrology, if that's okay. So I've compiled some evidence of what we do here. And this is a kidney walk put on by NKF, or National Kidney Foundation, every year. And this year, like the rest of the world, we had to go virtual. I posted here, this is our Twitter account, but this was posted on our Twitter account. And this is run by, like I said, the NKF. But we were second in the nation. It said third here, but by the time we finished, we were second for fundraisings in the nation. And this is how much we raised in the one walk. And these are all our people that submitted photos, and we compiled them into a collage to post. And so it was like a way to be together without being together. So that was really kind of neat thing. Just show you, we still have fun in COVID times. This was over Christmas. This was the crew that was in the hospital on Christmas Day, and we all made a decision to wear like our most obnoxious clothes. So he forgot, but he luckily has a lot of plaid clothes. So one of them brought him a flannel shirt. He wore his obnoxious sweater, and I wore this green plaid mom shirt that I was given as a bridesmaid for some wedding, in my obnoxious red pants. And so this was our holidays. We put a poll up on Twitter actually with this, our holiday spirit versus Flannel Friday teams. And it was rigged because his father rigged it, but Flannel Friday won that competition. And this is another collaboration we have with NKF, where we work with Duke Nephrology and their fellows. And this was our third year putting on a fellows night every winter. And it's usually a catered event we've done it at the Mez the last 2 years, but this year, again, we had to go virtual. Last year, we did it right before restrictions. It was like February. It's usually early to mid-February. So it was right before everything shut down. So this year we went virtual, and this is just an example. This is, we played Jeopardy this year, and Dr. Duranville from Duke hosts it. Because it went virtual, we were able to include our ECU and our Wake Forest colleagues and private practice people. So they got connections. It was a way for our fellows to connect with each other, but also with private practice. So it's kind of a really cool networking, but just another example of what we like to build bridges here in nephrology. And the fun we had. It was a lot of fun. And then I wanted to show some of our leaders in our division here. And I wanted to point out a couple of things. This is Dr. Coyle Jan. She teaches the medical student course, and she runs our fellowship program. And I would just highlight this comment. This was the end of the block there, the kidney block, where we teach about the urinary system. And she did a kind of a day in the life where her and three of our other leaders just kind of talk to the students about what it's like to be a nephrologist. And here was a comment during the talk. This lecture is unfair to all the other blocks. Our class is going to produce 80 nephrologists. So we were very excited about this. Coyle is a phenomenal teacher. She's won awards. She's kind of amazing. This is Keisha Gibson. She's the chief of our pediatric division. She is a local. She's from Durham. She went to Winston-Salem State University and then trained here at UNC. And she's just phenomenal. She's a national leader. She's on our national ASN, the American Society of Nephrology. So she's on the counselor and will be she's one of the council members and will be the president. I don't know how many years from now, in a few years. But she's just a huge resource to all of us. We're so lucky to have her. Everybody wants her in the whole world because she's so good, but we have her. And then this is Dr. Vora and Dr. Flight. Dr. Vora helped start one of our collaborative clinics with the cardiologists. And it's kind of that sort of bridge building stuff that is again, what we're known for. And she's a phenomenal teacher. And Dr. Flythe is my personal mentor, but she's our vice chair of our division and also nationally renowned for her dialysis research and on a lot of editorial boards and everything. She's basically does everything. And then this is Ron Falk, his face got cut off here, but he's our leader. He's been around forever. He's a dinosaur here. He's the chair of the Department of Medicine. He used to be our division chief when I was starting, and then he moved up to department chair to help our whole Department of Medicine. And he's a huge giant in the GN, the glomerular, that field of autoimmune diseases. He and his partner, Dr. Jeanette, kind of are the founders of that field. And he's basically known to any nephrologist knows who this guy is. So those are some of the leaders in our group here. And then to take you back to what it's like to be a nephrologist, I thought that these recent tweets kind of would give you an idea of what nephrologists think like, to see if it might be for you. So this was posted by one of our cardiology friends, and it's kind of one of those like short video clips. And this fellow was doing what's called a Bruce protocol, which is they make them treadmill. They're checking their heart out while they're doing it. So it's part of a heart test. And so she posted this with him, and this got a sudden reaction. So one of our fellows retweeted it and said, well, what's the nephrology equivalent of the Bruce protocol? And nephrologists from all around the world just started, I mean, I guess you can say it went nephrology viral, which is well, you think a very nerdy viral. And here were two of my favorite responses to it. My academic and social life has been building to this exact thread. Okay, we protein and salt load through Neph barbecue to give folks hyper, you don't have to understand all this, but folks hyperfiltering, then do the challenge with the winner having the highest 2-hour weight-based urine output. I bet someone will put out 4.5 liters in 2 hours. Hashtag life goals. So it's just an example of just how nerdy we are. This excited a nephrologist so much that we were gonna do that. And then this one came out later. Neph equivalent competition. Formulate the best solution of fluid and electrolytes plus right volume to hand to guy on treadmill for adequate volume repletion, and winner gets patent. We protect kidneys from hemodynamic compromise. Nephrology doesn't break a sweat and saves the day. So we're also a little bit competitive with our nerdiness. So I got a real kick out of these. And one other thing to demonstrate just how nerdy we are. This is something that's been going on, I don't know how long. This is started by my colleague at Duke. And it's actually just taken full force, and other specialties now have their own, like Room has one, Room Madness. And it always comes out in March, and it was obviously modeled after March Madness. And it's kind of just our nerdy way. Each team is a different topic, and they're in different region, which are subtopics, and they go head to head. And there's a blue ribbon panel that decides what's more interesting. And everyone submits their brackets. So it's just kind of goofy nephrology fun, and picks a champion. And these are, this was this year's brackets. And as Margaret mentioned, today is World Kidney Day. So happy World Kidney Day. And one of my colleagues posted this, and I thought this was hilarious because if you've ever seen a picture of or a slice through a kidney, this is kind of what it looks like. So, and I had never thought of this. I'm like, wow, we see kidneys everywhere. So I think that's the end of my show, and I hope I've given you an idea. And here, this is our website and our Twitter account. You can find a lot of activity in our Twitter account. So I hope that wasn't too boring, and happy to take any questions.
Thank you so much, Dr. Chang, for presenting that. I think we all gained insight on what you do in a day and what the typical, what the typical nephrologist does. So yeah, if anyone has any questions, feel free to drop them in the chat or just shout them out and unmute yourself. Anybody can go ahead and ask. I personally have a question about, so how did you choose nephrology as your specialty? Like, were there any others that stood out, and how did you narrow it down? Like, what was your process with that?
So when I started med school, I thought I was going to be orthopedics because I love sports and I play a lot of sports. And I guess I thought that if you're an athlete, you should do sports medicine. And I even started a sports medicine interest group. And then it was during the first year medical student urinary systems course. And we have small groups, and they're led by a faculty member and a trainee. And I think that's when I had very enthusiastic leaders who were really heady like that. They were very very thoughtful. And I think their enthusiasm and their quirkiness, they were nerdy and thoughtful. And I immediately thought, I want to be that smart. And I'm kind of weird too. So that seems like it would be right for me. And that got me thinking of it. And actually, right before that course, we had the gastrointestinal, the GI course. And I also really love poops. I guess I like all excrement. So I really like poops too. But I kind of figured out that gastroenterologists don't so much like poop. They like all the poop to be gone so they can see what's going on outside. And I just like poop. So I decided in the end that wasn't for me. So I had a brief thought about GI. But my personality just really fit with the kidney doctors and kidney doctors are also all the medicine specialties, and really all the specialties, they sort of have this personality stereotypes. And it's not true, obviously not true for everyone. It's just kind of a general, but it's a way to think about would I like hanging out with these people all day? You don't have to be like them, but would you be annoyed hanging out with people like that all day, all the time? Because you do end up spending a lot of time with them and having to collaborate and work with them. And I just found that the personalities of these two people seemed to really excite me. And then the more I worked with other nephrologists, it turned out I was right. Every nephrologist was sort of in some way quirky and nerdy. Doesn't mean we're all smart. Like, I didn't think I was smart. I thought I'm not smart. So if I hang around with a lot of smart people, it'll rub off on me. And one day I'll be smart.
Okay, I think we have a question in the chat asking, why did you choose to be a physician, and would you do anything different if you were to do it again?
I started med school really late. Well, really, I didn't think it was late, but it was late compared to everyone else. I started at age 30, and I really did choose to be one because I tried not to for a long time. I was in school to get a PhD and then dropped out because it turns out it wasn't right for me. I don't know why. I maybe thought I didn't think I was going to be a teacher. I taught for a few years stalling till I figured out what I wanted to do. So it took me a long, long time to figure it out. And I think I finally figured out while I was stalling teaching, because I kept teaching about a lot of biology topics. And I did like the people aspect of teaching. I just didn't like disciplining. So I think I kind of thought, I do like science. I do like people. I don't like discipline. And And I never wanted to be a doctor. I always thought this is too stereotypical for an Asian. Like every Asian I knew in college was pre-med, so I didn't want to do it. Um, so I guess that's how I fell into it. I mean, how I chose it. And would I do it differently? I don't know if because I wouldn't have wanted to start earlier because I needed all that life experience. It took me a long, long time to grow up. Like I really had no idea what I was doing. I didn't actually make well thought out choices until the choice to go to medical school. I mean, I kind of bounced around every 2 years from something to another, doing what I thought I was supposed to do, what I thought I liked. But I guess that gave me the experience I needed to really be committed, because when I did med school, it made med school easier for me. Not that I aced it. I wasn't a star student. I wasn't terrible, but I wasn't star. But it allowed me to not stress out about it because I was older and I knew that it just wasn't that big a deal. I just needed to pass. So it allowed me to enjoy med school a little more than some of my colleagues. So I'm grateful for that reason. But if I would have done it differently, I think I would have maybe been more mature. But I don't know how you can ask yourself to be more hey, would you have been more grown up than you? I don't know. Sometimes I look at you young people and think, oh, they're more mature than I ever was. I just randomly said, I'll do this, whatever. I don't really know what I'm doing. So I think if I could have been more mature, I wish I would have been more mature, but I end up where I am and I'm pretty happy. I have a dog that I love and really like my job. I fell into that part was again sort of by accident. So I'm not really great at choosing things. So I just got lucky. I guess I have a lot of luck, and a lot of privilege in my life got me to where I am. So I recognize that too. And there's a question from Jackie.
Hi, yeah. Well, I guess you kind of answered the question that I had if like you were like the traditional versus like non-traditional medical student like pathway. And I was just kind
So
of
non-traditional.
right, because I just find it interesting like to hear that people come from like a lot of diverse backgrounds and just ways to getting there. But I also had a question in like how did you kind of do it? Because you started at 30 and then, like did you have to like retake a whole bunch of classes and like was your GPA good? Well, not really specifically your GPA, but like
yeah, I had to retake. I think the only one I had to do was physics because to get my thankfully my degree was in biology, so I had a lot of the courses already, and I was in grad school, so I think a lot of stuff I was able to carry over. But again, I was lucky there. I think you would, starting that late, if you hadn't have done biology, you would have to go back and take a bunch of stuff. And I know people who've gone back later that have done it, but it's easy to get those credits. You can just go to a community college, take a cheap night class. It's just getting credits. It's not, I mean, it's hard in that it's time consuming. It's not like in college, every class stresses you out. If you're passed and you need to retake some classes, I'd say just enroll in a community or tech college, get the physics under your belt, learn the material, and apply to med school. So I'm a big proponent of don't get yourself in a lot of loan trouble early, because it'll take a lot to dig yourself out later, and it'll affect your choices you have to make later in ways you don't want it to. So choose things that are cheaper. And Dia has a question.
Yeah, I was just gonna sort of ask a similar answer. My leg's being weird. Oh, okay, well, that turned.
Now you're like those people who don't want their identity known.
Okay, my bad. I don't know what is going on today, but I just kind of, I guess, also wanted to say, like, I'm not entirely sure I wanted to go to med school or not, just because I feel like I have a lot of different interests, like with like maybe just like global health or like public health type of stuff. So, I'm like still kind of trying to decide that for myself. So it's like kind of nice to hear that like it's okay. Like I don't need to necessarily know that right now. So, but I was also just wondering, sort of like for me to, figure out if I would like to go to med school and pursue something like that. Like, what was your favorite part of like your either med school or like residency or just training or something?
I really liked people, getting to know the people. So in med school, I loved getting a study group, which is why I feel really bad for the people who just did first year because they couldn't have study groups. I loved having the two people I studied with all the time, because I wasn't really great at studying, and it helped us to kind of we sometimes all we did was sit in the same room, but it made us keep going rather than taking 10,000 breaks. And I guess I'm a people person. So that was probably my favorite thing about medical school, was just the connections you develop. And then training, I also really loved my residency fellow trainees. We didn't have a great class. We had kind of a lame class, but it's still really fun. We had some real jerks in our class. We had some really cool people too, but and I really liked, that's when I solidified that I was interested in nephrology. So I kind of chose to do a lot of nephrology rotations, and it was fun getting to know all the nephrology doctors. It was scary. I felt like residency was your first chance really working with patients, and I didn't know at that time how I would be with working with patients, and it's 10 years later and I'm only just now feeling confident about my ability to interact with patients smoothly. It takes a long time to develop that, but I enjoyed the co-trainees a lot too with that. I think just being with people in the same boat as you, and you think it's never going to end, but it really does. I mean, it's hard, grueling times, but it ends. Rishab, you have another question? I don't know if I said your name right.
That was, I think, perfect pronunciation. Yeah, so I kind of had a question. I know COVID has really changed a lot of like stuff in the medical field, but as like a physician, how do you view medicine changing in the next, like if we decide to become physicians, whenever we become physicians, how do you view like medicine changing in terms of like insurance stuff too? Because I know that's definitely a big topic of concern.
Oh my gosh, I think it's going to be so different. If you become doctors, I think by the time you're doctors, it's going to be so different. I mean, some of the stuff will be the same, but there will be technology so fast. I cannot keep up. I'm not really a technologically sound person. So it's a struggle for me. I have to devote more and more percentage of my brain to figuring that out. But you guys are a lot better at it. So I mean, you probably don't realize it, but the amount of my brain that I have to do just to figure out how to sign up for something is really hard. So if it takes less of your brain power, you'll be able to put it more on some of the other stuff. And I just think things are going to move a lot faster. For example, ultrasound. That's one of my research projects, is looking at something called point of care ultrasound. That wasn't a thing when I started training, and it's a thing now, that instead of stethoscope, it's sort of the new stethoscope, that everyone will soon have a ultrasound probe to carry around with them and standard physical exam. I mean, that's not a thing yet, but it's sort of one of the changes that is being looked at, is happening. Electronic systems, televisits, all of that is going to evolve and change, and I think it's going to be so different. Insurance, I even wondered about my own, because we have great insurance here at UNC, but I thought, well, if insurance changes, we should all get insurance, and it doesn't matter if I have great, we should all have the same. So I don't know if it's going to go in that direction, but it will change things a lot. And you may have whatever view on it, but it will change things for my patients. I mean, a lot of my patients who don't have access, I spend a lot of their visit trying to figure out how to navigate what medicines that they can afford. How do I figure out what medicines that they can take, that they can afford? How do I get them? So yeah, I spend a lot of my brain power on that. And if insurance were to change for the better for those people, I would be able to just prescribe what I want to prescribe, and they could take what they want to take without having to do acrobatics to get what they need. So many ways that I can't even envision. I'm not really that creative a thinker either, but I know there will be things I have not thought of. I mean, in the field of nephrology, there's talk about wearable kidneys. They're trying to build artificial kidneys that would change the face of dialysis. I think that's still many years away, but it is a thing people are doing. So that would change kind of a whole new area of what of care, if that were something we had to take care of, how to take care of wearable kidneys. So many things. Jackie.
Okay. I have another question about the process. So when you went into residency, that's like when you already knew you wanted to be in nephrology, right? So is there like, I know that there's a thing called match day. Is that like based on like your other doctors, like I guess the senior doctors, like kind of rate you on what like rotation you did best, and then you kind of get put into there? Like, do you have a choice to like do something else, or was that like your best skilled one?
No. So match day is at the end of medical school. So you have gone, at that point, you would have gone through rotating through the 6 basic specialties, which includes medicine, surgery, OB, pediatrics, family medicine, and I can't remember, but there's 6 main specialties. And then people who have interest in others, like more specialized things like radiology or emergency medicine, they will have done rotations there too. And so you pick kind of your specialty area that you're interested in, and during your 4th year, you apply to residencies in that area. And some people may pick 2 because they have to do a prelim and like for dermatology, you have to do a preliminary year before you go into dermatology. So they may have to do 2 sets of interviews, but you interview at all these programs that you get invited to interview at. And then all those programs will rank you. They'll rank all the people they've interviewed. So 200 plus people, they'll rank them in order. You will rank however many programs you visited, 5, 20, 50. It depends on how competitive your specialty, how many you have to visit, and you will rank them. And goes through a big system, computer system, and it matches up so that your highest rank that also ranked you their highest before they filled, you'll be matched there. And that's the match day. And everyone gets their envelope the same day. And that's just for the first step. So I didn't pick, that was at the end of medical school, and I picked medicine at that point. And I did know I wanted to go into nephrology, but medicine is the specialty. And then from medicine, if you decide you want to go in nephrology, then you have to do another round of applications. When you finish medicine residency or any of those, OB, any of those, you can be a practicing doctor once you finish that residency. So when I finished medicine, I can practice, but I decided I wanted to do nephrology. So I had to do a whole nother round of applications into nephrology programs, which was another 2 years of training, which turned into 5 for me. And once I finished that, I was certified in medicine and nephrology. So for instance, like if you wanted to be a surgeon specializing in oncology surgery, you would do surgery. I think you do a prelim year in general surgery, and then you would do however many years of oncology surgery. I actually don't know how the surgery side goes as well as the medicine side, but for medicine, it's usually 3 years in medicine, general medicine, and then 2 to 3 years in your subspecialty.
All right. Are there any more questions that anyone has?
Well, I have one last quick question.
Yeah, go ahead.
So I know that med schools right now, they've made, I think, USLME the board score number 2 pass fail. I think they're trying to make number 1 pass fail, or did they make 1 pass fail? I'm not sure, but they made one of them pass fail. And so how do you think that's going to affect like choice of residency? I know that was a major factor into residency choices. How do you think it's going to affect the residency process?
Well, I hope that, and I think didn't they also get rid of step 3?
I
which
think so. I'm
is
I'm
really
not quite
good.
sure.
I'm very glad about that because that was just a money suck, really, is all it was. So I think and hope that will make residency programs a lot more diverse because, like I said, to me, medical school and how you do in your classes, that doesn't tell how good a doctor you're going to be. Uh, I think I'm a pretty good doctor, and I did, a little above average in medical school. But I think my patients would say I'm a very good doctor. And I think that just all that emphasis on how well you do, it just makes for an unhealthy environment. It makes for unnecessary competitiveness. And it makes for people feeling like sometimes there's people will go into certain specialties because of the respect, or they want the name, the title. And I think that's dumb. I think people should really be able to focus on what it is they enjoy, what brings them joy, what makes them want to get out of bed. And I think to that line, there has to be more and more parity in pay for different specialties, because sometimes the high competitive specialties are the one because they pay a lot, and that's just not fair because they don't necessarily work more. So I think that the more and more we make things pass fail, all you have to do is, I think that you just need to jump through the hoops, because that doesn't determine how good a doctor you're going to be. What determines is the training you get when you're actually on the job in training, and how seriously you take it, and how much you listen and absorb, listen, learn from your patients, from your mentors, from your colleagues. And it just takes experience, and I think that's just a grind. Your step scores shouldn't matter that much, so I'm very in favor of that. Jackie. Oh, Jackie, I also wanted to say on your last one that you can, and sort of tying together to your other question too, you could always choose a specialty and then change your mind. Like, that does happen. So you're not tied into that either. One of our nephrologist fellows with me, he was actually going to be neurology, a brain doctor, and he did his preliminary with us, and he changed his mind, decided he wanted to be a kidney doctor because he realized the kidneys were smarter than the brain.
As of right now, I'm like, I don't even want to think of I don't want to I guess not specialist because I'm still an undergrad, but say which one I want to go into, because my brain, my mind changes really easily if I end up liking one. So right now I'm just keeping my options open. But I had one more question. I know we're kind of over time, but I just wanted to know if you work with any physician assistants, and if do you see any differences, or I guess the job duties and the descriptions, because I kind of see them very similar, except physicians have more autonomy and full control of their patients and last say. But yeah, I'm just kind of curious about that.
Yeah, and I think that a lot of that is evolving. You probably get different physicians with different opinions. I love PAs and NPs. We have a really good PA school at UNC, and the one time I got to teach them, I did 1 or 2 lectures, and I loved it so much. I feel like PA students are a lot more real world than med students. So I think that on the job, what they do for me is they can do a lot of what I do. And right now, the way it is, they're kind of overseen by a physician. But a lot of the stuff that I do, a physician assistant can do. And then that frees me up to do some other stuff. But I think PAs get to do a lot of direct work with the patients. And that's really nice and fun. And they have the ability to do a lot of what I do. Some physicians don't like it as much because they're a little bit territorial. They don't necessarily want to share that. But I think if done in a collaborative way, if you have a good relationship, it's really potentially very strong. We actually have more NPs here at UNC Nephrology in our program, and it's different, but essentially they're both physician extenders, and we rely on our NPs. I mean, actually one of our NPs who's been doing our inpatient program works with the fellows, and they thank her every year. She's trained every fellow that's come through our program. Not one of us has not owed our inpatient training to her. And we're all scared for her to retire because she helps all the faculty. Like we can't do it without her. So I love PAs and NPs personally.
Thanks.
And I think a lot of PAs and NPs end up more rural places too, that for some reason physicians have a harder time going to, and that's nice too to have. And I presented to a group of NPs, and they all have my email and number, and they still call me to ask me sort of on the fly consults because they don't have a nephrologist out there.
Thank you. All right, thanks for the questions, guys, and thanks for the great answers, Dr. Chang. Thanks again for presenting and spending some time with us tonight. To CHSS members, we do have a quiz if you want to get attendance credit and get some shadowing hours. So Rithika just dropped that link in the chat. Go ahead and fill that out. I think you have 20 minutes to fill that out to get credit. It's just a couple quick questions about the presentation today. And yeah, thanks for coming out, everyone. Thank you, Dr. Chang.
Thank you.
Thanks.
Bye-bye.
Bye.